Good evening, everyone. I'm Dimitrios Kostopoulos, and I am the co-founder of Hands-On Seminars, and I'm delighted to welcome all of you tonight in this amazing webinar with Dr. Leon Chaitow as a guest. But before we start, I would like to find out a little bit from you where you are logging in from tonight. So if everyone real quick answer this question online, you can just click and let us know if you are logging in from the US, from South America, from Africa, from Europe, or from any other place around the world. So a couple of more answers to go. I'd like everybody to participate. That's great. And it seems that we have 38% of you are joining us from the US. Nobody from South America tonight. And 8% from Africa, 15% from Europe, and 38% from other places around the world. So we have to, you can certainly type in the chat box where exactly you are logging in from, so we know. And also please answer this question whether you are a PT or a PTA, an occupational therapist or an OTA, a medical doctor or a DO, an ATC or a massage therapist, or any other professional. Okay, and I am closing this poll, and it seems that tonight we have mostly we have mostly PTs and PTAs with us. So again, thank you all for joining us. As I said, tonight we have with us Dr. Leon Chaitow, who will be discussing with us a very, very important topic on positional release, therapy. Sorry about that. I am having a little trouble with my screen. Okay, we're back now. I would like to mention that Dr. Chaitow, besides being a world-known naturopath, osteopath, and acupuncturist in the UK, he is also the editor-in-chief of the Journal of Bodywork and Movement Therapies, and it is actually the Journal of Bodywork and Movement Therapies is the official journal of Hands-On Seminars, and I will invite all of you to go to the handsonseminars.com website and subscribe for the journal. But also, if you are an MCMT student or graduate, you are receiving as complimentary from Hands-On Seminars your first year of subscription completely free of charge, and subsequently you can continue subscribing to the journal at a very low price. With no further delay, I would like to go ahead and introduce you to Dr. Chaitow, who will discuss with us tonight the very interesting topic of positional.
Pardon me.
Okay. Leon, you are on.
Okay. Good evening. And let me put my slides on the screen and clear the screen. I don't know. Dimitri, can you tell me whether that is
yes,
showing adequately?
It's fantastic. We can see your screen. That's perfect.
Okay. So let me take you through this topic, which I find to be one of the most exciting aspects of manual therapy, which it has emerged out of a background of osteopathy. Part of the methodology goes way back to the beginning of osteopathy, but much of it has evolved in the last 30, 40 years, mainly in the States. If we look at the main forms of positional release methodology, they can be divided up into what can be called functional methodology, where the tissues are joint or soft tissues are eased, moved, folded, gently taken into what is considered by the practitioner based on palpation a position of comfort, ease, relaxation, where hypertonic tissues are eased into a state of comfort and support where some form of possibly neurological, possibly circulatory, we're not sure of the mechanisms, and we'll talk about that a little bit later, changes occur and quite dramatic modification in function occurs. That model, the functional approach, we practice in the workshops, and it's not difficult to learn, but it's not in areas where you have good control over the structures, small joints or possibly the cervical area. But in the main, the other method that is most used, and the one that we spend a lot of time on, is a modified form of strain-counter-strain, where tissues again are taken into an ease position based on feedback from the patient. So an area of sensitivity, a tender area, is identified, usually in hypertonic structures. The patient is asked to provide feedback in terms of a numerical feedback. So if I find something in a soft tissue that is uncomfortable, I ask the person to grade that for the purpose of the exercise as a 10, and we gently, following particular protocols which are well established, take the tissues towards what would be reported back as a score of 3 or less. So we start with a 10, get down to a 3, and in essence, whether you're using the functional approach where you're guiding the tissues into a comfort position based on your palpation skills, or whether you're using feedback from the patient, you're going to end up in much the same place. A degree of facilitation, that's the third item on the screen, involves adding either a compressive or a distraction or a shear force to the tissues, which makes them even more comfortable. Now, all of this sounds, if you're unfamiliar with it, a little bit odd, but let me take you through other variations which often involve exaggerating any existing distortion, so that if something is hypertonic and short, the ease position is actually going to hold it in an even shorter, unloaded position. Often the ease position is a replication of a strain position. Something happens when you're flexing, and the ease position, that something might result in a back pain or a hip or sacroiliac type pain. The ease position is going to be virtually a replication of that position, but in a supported position. You can also work from prescriptions, which is very much the Jones strain-counter-strain model, which we look at, but we believe we found much more simple ways of identifying ease. And going through this little list, you can see that there are different ways of ending up in more or less the same place. That is that ease position. You can use palpation, or you can use patient discomfort as a guide, or you can add facilitation, or the methods known as mobilization with movement, the New Zealand Mulligan approach, has echoes of positional release, has elements of it, or taping, which unloads tissues, McKenzie methods where movements are in directions of comfort rather than anything that exacerbates pain, and in sacro-occipital technique in chiropractic using blocks for support. All of those are variations on the theme of positional release. And these images this this one which I'm circling with the little cursor is a strain counter-strain model where a tender point is being monitored and the arm is being positioned until the pain disappears from that tender point. Mulligan's work uses glide of joint surfaces, actually joint play, as a means of achieving something similar. McKenzie methods move patients into their comfort or ease positions, which reduce pain. Taping can unload tissues. Sacro-occipital technique uses blocks. So there are variations on that theme. There are a number of others which are listed here. They're all based on traditional osteopathic methodology, Still's technique or balanced ligamentous tension or fascial unwinding, variations on a theme which are all relying on that ease position, which is found in different ways. Lawrence Jones, osteopathic physician, identified multiple points on the body which he regarded as useful in easy or monitoring points for treatment of particular joint areas. This is a superb model, but it requires memorizing literally dozens, if not hundreds, of different points on the body, and we find in the modified version that we teach that this is quite unnecessary, and this is a sort of complicating factor which can be avoided if you use a particular formulation for identifying movements that are painful or movements that are restricted, and then targeting the soft tissues that are potentially restraining free movement or being pain generators. And within those soft tissues, localized areas of pain or dysfunction would be identified and used as that monitor as you position tissues into ease, and a resolution or a partial or total resolution of the dysfunction occurs. So the objective of all of the methods, the key objective, is to restore tissues to normal physiological function. And tender points are used. It's useful to just talk about tender points. These are not necessarily trigger points. Anything that is tender, that shouldn't be tender, is potentially useful as a monitor. And that's used as a guide to positioning three-dimensionally in flexion, side bending, rotation, shear, translation, and so on, to identify positions of maximum comfort. And that can be the terminology there. You'll see the word ease or dynamic neutral. These are all comfort. These are all potentially the same thing. Starting with a score of 10, reducing by at least 70%, adding a facilitating compression, and then maintaining that position for a short period before gently releasing. A functional technique here is illustrated here in this rather ambitious, shall we say, illustration, where palpating hand, this listening hand, is assessing tissue responses to movements as illustrated by the arrows into flexion, extension, side flexion, rotation, shear, forces, translation, extension, compression, and so on. And in each of those positions, there will be tissue changes palpated, and one position of comfort is stacked onto another until a maximum position is identified, and that is held and then changes start to occur in those tissues. Same thing can be done, perhaps, for example, in a shoulder joint or any joint that you can control and monitor during positioning. There are studies. These are a couple of studies listed here, 89 and then 2005, looking at the use of these methods post-operatively to enhance tissue healing, where you can't see it clearly here, but this where the cursor is moving, this arrow, this is an arm, and that hand would be underneath the patient between the shoulder blades. This hand is on the chest. Let's say there's been sternotomy and there's scar tissue here, and each hand would identify directions of movement of comfort of skin on fascia and superficial fascia on underlying tissue, and that would be held. These methods enhance healing quite dramatically, and these studies demonstrate that the hemodynamic changes that occur following this sort of very gentle manipulation, which actually starts with the patient very soon after surgery. A very similar method is known as integrated neuromuscular release, where here the patient is seated. Each hand would independently identify directions of comfort, moving superiorly, inferiorly, laterally and medially, rotating clockwise and anti-clockwise, and for each hand finding a combined position of comfort, which the patient would only have a sense of. These are all assessed by direct palpation from the practitioner, and a useful study here showing benefit, this is a 2003 study, in tissue responses to hypertonic tissue responses to this sort of gentle approach. Direct use of translation in the cervical area can do something very similar, working on the mechanisms involved in spinal coupling, so that as joints are translated gently, one direction may feel more restricted than the other. The tissues of the segment is taken in the direction of most ease and held, and after 30 to 60 seconds, a degree of normality is identified subsequently. So we actually use this as a workshop exercise. It's also an extremely useful clinical model for sensitive cervical areas, especially post-traumatic or during recovery from injuries such as whiplash. A functional method of treating the atlanto-occipital joint is illustrated here, where all directions of movement are introduced with this palpating hand, sensing tissue response at the atlanto-occipital area during different directions of movement, and subsequently a combined position of ease is identified and held, and that's another one of the workshop exercises we do, and this is an extremely profoundly relaxing and useful way of easing atlanto-occipital dysfunction. There are a number of studies showing animal positional release. The sort of injury that jumping horses can experience. In some of the studies where thermal imaging is used pre and post positional release, the results are outstanding. They measure also the horse's stride length before and after treatment. This is a positional release of the atlanto-occipital area, cervical complex. Horses are extremely obliging. So anyone who works with animals can use positional release extremely effectively.
Leon, sorry for interrupting you. Just want to make it a little bit more interactive, if you don't mind.
Sure.
I want to find the opportunity to ask you, in terms of the response of the muscle, do you find a difference in the timing of the response, or the way the feeling of the response of the muscle between humans and other animals that you have seen or treated, or in between the different species of animals? Any difference?
Well, my experience with animals, Dimitri, is limited to dogs and cats. I haven't treated horses, but I have colleagues who have.
Right.
My understanding of treating horses is that the response is relatively quick, and that horses seem to assist in the process. They move, if, as you see in the illustration on the top left here,
correct,
the practitioner is both palpating and feeling. The horse seems, feeling the tissue response, the horse seems to be helping, assisting in the movement. There's no sort of force used. The horse will automatically move into an ease position. What the practitioner is trying to do there is support it.
Correct.
And help it. My experience with dogs is that they respond usually, except for one bad-tempered Chihuahua that I don't want to talk about, but otherwise most dogs do seem to be extremely responsive. If I palpate tension in the neck, now I don't treat dogs professionally. This would be outside my scope of practice, but I have treated our own and friends' dogs. Just because this is such a simple thing to do, you can do it without anyone knowing you're doing it. You're feeling the neck or the spine and gently moving into a comfort position. You certainly know when you're moving away from that ease position, because the dog will be restless and the dog will not be happy. But in a comfort position, the tissue response is quite rapid. 30, 60 seconds, if you can, is a norm there.
Thank you.
But as to horses, I give this as an illustration. There's a chapter in my positional release book by osteopathic practitioners who work with horses, and that's I just find it fascinating. They also talk about their illustrations that they've sent me, working on various zoo animals. There's one working on an elephant, where there are 4 practitioners working on it at the same time. Quite remarkable. But what I'd say is, as an example of, I don't know if there's a placebo effect when you're treating an animal. There may well be, but I find it hard to believe. If a horse's stride length improves and you see a circulatory improvement with thermal imaging in a horse that's been traumatized, I think it's fairly clear that something very positive is happening physiologically.
Correct. Thank you.
So the mechanisms that are hypothesized are neurological and circulatory by various people coming up with models. There's very little evidence. We'll see some evidence in a minute of recent research which does give a different clue. Spindle resetting is a model. Changes in hysteresis, the density or the tension, or if you like, the lack of elasticity in connective tissue. That's a very recent study, and we'll have a quick look at that a little bit later. Changes in pain sensitivity. Paul Stanley at the University of Arizona Medical School has found on the cellular changes, fibroblast morphology changes during positional release in a laboratory model. And Solomanoff from University of Colorado talks about ligamentous reflexes when we add distracting or compression forces. So there are a number of different models, all of which may be correct or none of them. They all make sense in a way, and I'm sure somewhere in that cocktail we have an answer, but I don't think there's anything definitive yet. This is just a study which showed EMG changes with positional release. Patients with chronic cervical dysfunction received positional release of the upper trapezius for 90 seconds, twice weekly for 5 weeks, and there were very positive changes as an outcome there. Hysteresis, which the definition is basically the rate at which connective tissue responds to loading or unloading. This was a very recent study that we're going to see in a moment, which was done, I think it was done at the University of Philadelphia, yes, College of Osteopathic Medicine, Philadelphia College of Osteopathic Medicine. So they used this durometer, which gave a piezoelectric impulse to each cervical segment to measure the current response to that particular load. They then treated these cervical segments using either muscle energy, CounterStrain, balanced ligamentous tension, or high velocity manipulation. They measured, they used the term motoricity to represent the overall dysfunction of a segment, and it includes mobility and the length of the curve and fixation. So somehow they're measuring change, and they found that strain counterstrain produced the greatest overall change in tissue behavior. That's the CounterStrain bar there. All of them produced change other than sham, which produced no change. and the study here, which involved 240 patients, or not patients, students, palpated for cervical and articular somatic dysfunction, and they used those particular techniques, having used a gyrometer to measure myofascial structures with this piezoelectric impulse. So, CounterStrain resulted in the most significant change, which is interesting because that's one of the models that we're going to be teaching at the workshop, and one we won't be teaching is balanced ligamentous tension, but that is another form of positional release, but that's a different study in and of itself. One of the models that may be involved here is mechanotransduction, and we don't have time to discuss this in depth here. Mechanotransduction is the way cells respond to load, and this is an example of it from Paul Stanley's research. These are fibroblast cells. This is the control model. They took these fibroblasts and they spread them over a rubber dome, an elasticized dome, which was in a vacuum chamber, and then they were subjected to 8 hours of repetitive motion strain as they were flexed and extended. That rubber dome was moved up and down solidly for 8 hours. You can see fairly dysfunctional, damaged, moth-eaten looking cells here, and there were a number of inflammatory products being produced. Then after 60 seconds of CounterStrain, where all that was done was that rubber dome was held in a slightly compressed form, exactly equivalent to a model of what would be done in the human body. And the inflammatory products reduced, and fibroblasts became far more coherent. So it doesn't prove anything, but it gives a sense of what might be happening as cells modify in structure. Their behavior changes, and the CounterStrain model, the positional release model, may be offering a degree of coherence and support which allows more normal function to be restored. That's the concept anyway. And then another study on this, using the same idea, and the quotes here are useful. Let's just look at this lower one. Human fibroblasts respond to strain by secreting inflammatory cytokines, undergoing hyperplasia, altering cell shape and alignment. Tissue changes, whether resulting from injury, somatic dysfunction, or osteopathic manipulative therapy, soft tissue manipulation such as strain counterstrain, affects range of motion, pain, and local inflammation. On a cellular level and in a laboratory, we can hypothesize that this is what's happening in the human body. This is just a reminder. Solomonoff notes that when ligaments are held in a slack position, which is what happens in, for example, strain counterstrain, here we have piriformis being monitored, a tender point there, and the ease that's uncomfortable at the start, scoring a 10, or not the patient's report of a 10, but the patient told to score it as a 10. And then with a degree of abduction and external rotation and long axis compression, which would load the ligaments and slacken them, that tenderness vanishes, and subsequently more improved function. And Solomonoff hypothesizes that that ligamentous slackening is what produces a reflex effect and enhanced function. These are just selected studies. We can't look at them all, but just effective strain counterstrain on pain and strength of hip musculature, strain counterstrain treatment of patients with low back pain, stretch reflex and Hoffman reflex response, that is with strain counterstrain in subjects with Achilles tendinitis, myofascial pain unresponsive to standard treatment, successful use of strain counterstrain, comparison between the immediate effects of manual pressure release and strain counterstrain on latent trigger points in upper trapezius, strain counterstrain treatment of quantitative sensory measured at digitally tender points in the low back, and headache treated by positional release. Complex regional pain being treated using strain counterstrain. Another one here is counterstrain in plantar fasciitis. This is a application of strain counterstrain in upper trapezius tender point. These were studies back in the 90s on sacroiliac tender points, low back pain, treatment of forward and backward sacral torsion using CounterStrain. Similar CounterStrain techniques. These were the same group at the Texas College of Osteopathic Medicine. This is looking at masseter trigger points, comparing neuromuscular technique and strain counterstrain. This is an elastography image of normal tissue. That's with a trigger point in at the dense area, and the idea that you can image the before and after and see that the thing changes using various techniques. You could use dry needling, you could use neuromuscular technique, but positional release strain counterstrain is probably the most gentle approach, and it has the same benefit. This is an Indian study where strain counterstrain was used as part of a trigger point deactivation, efficacy of integrated neuromuscular inhibition technique in trapezius trigger points. And this was this methodology we practice in the workshop uses strain counterstrain as part of the protocol. And that's my dog, and that's the end of the presentation. So I'll put myself on the screen for a moment and see if I can. That's not me. That's me. So I'm happy to deal with questions and anything that you can ask me, I'll be happy to try and answer. That was a fairly quick gallop through the idea of position release, and for those of you unfamiliar with it, I hope it's just given you a sample of what's possible.
And let me tell everybody that you were kind enough tonight to be joining us from the UK, where we have quite a few hours of difference. So thank you for doing that, and I'm going to actually unmute the mic of Amanda Meglio. Amanda, you have a question. You are on the air. Go ahead.
I didn't ask a question. I didn't say that I have one.
Okay, very good.
But I do have one. I wanted to know about strain, counterstrain, and stretching afterwards. What you believe the importance is of it.
Okay. It depends what you're treating there. We use, in that protocol for trigger points, we use strain counterstrain as an intermediate step towards local stretching. So we would put tissues into an ease position, and in that ease position, depending upon the sensitivity of the patient, we might hold that for 20, 30 seconds, and then using that folded state, have an isometric contraction surrounding the trigger point. So we get a very local, focused isometric contraction, which we then use that as the lead into some local stretching. But not everything needs stretching, but where stretching is used, positional release or strain counterstrain can be a precursor to the stretch, or it can be used afterwards to calm things down if there's been some degree of irritation or discomfort as a result of the stretching. So it's something, I don't think I would ever give a positional release treatment. It would be part of an integrated methodology, I think, and that's how I would tend to use it. I hope that answers your question.
Whoever else has a question, you can type it, or you can click on the raise hand feature, and I will unmute your mic so you can ask the question. However, we do have a question here from Mariana. She says, have you done strain counterstrain when there is muscle soreness after extreme eccentric exercise, and how?
Well, it's always the how is not difficult to answer. The answer is yes, I have, and anything that is uncomfortable, that shouldn't be uncomfortable, you can find localized areas which are more sensitive than others. Those are simply let's put it this way, in traditional Chinese medicine, in acupuncture methodology, there are the so-called Shi points, points that are sensitive, that are not on the meridian maps. And these spontaneously tender points are, in acupuncture, they become, if you like, honorary acupuncture points, and they can be needled. In strain counterstrain, in the modified version that I teach, anything that is tender that shouldn't be tender becomes a potential monitoring point for ease, for being placed into ease. And whether you're treating something that is chronically uncomfortable or acutely uncomfortable. The same rules apply. You simply find, identify 1, 2, or 3 local areas of tenderness, and using the protocols that we teach, you crowd the tissues, fold the tissues, hold them at ease without creating any additional discomfort. You then hold them until a certain amount of time has passed, 30, 60, 90 seconds maybe, or until you feel a spontaneous change in the tissue behavior. And so it's irrelevant whether it's acute or chronic. The likelihood is that you're going to get a much more rapid and lasting change in an acute setting than you are in a chronic setting, where there may be fibrosis and other tissues that can't just let go. But where you have hypertonicity, for whatever reason, that you can change.
Very good. And if anyone else has a question, you can either type it now, real quick. Do you have... another person is asking, do you have... what happens if it is very painful in the beginning? And also... just answer that, and I'll ask you the other one we have from Robert.
Well, if tissues themselves are very painful,
yes,
then there's almost always, you know, from the McKenzie model of movement into ease or movement into comfort, directions of movement that are more acceptable to the tissues and some which are not. Usually, almost always, making tissues shorter, somehow supporting and holding them and crowding them, makes them more comfortable. And that would be the model. If you're dealing with something, for example, on the anterior thorax, if I found something sensitive and extremely tender here, the methodology would involve some degree of flexion, some degree of rounding and folding towards it. If that was in the intercostal space or just below the clavicle, somewhere in that sort of area, then I might be monitoring the point with one hand, holding the patient in a crowded position, adding some degree of compression, and the sensitivity would vanish while I was holding it in that position. If you think about it, this is very similar to what some forms of taping do, just holding the tissues in a folded or shortened position which is comfortable. And so the degree of sensitivity initially should be reduced by using the protocols we have for positioning, and that's almost always the case.
Okay, let me go on and ask, because we have a lot more questions, so let's get the question from Robert. What is the difference between your applications of strain, CounterStrain, and Jones or Sharon Weiselfish?
I don't know a lot about Sharon's work. I've read a little bit of it. The Jones model, initially, he discovered this quite accidentally on a patient, this whole idea that there was an area of tenderness which he could position and it would help to resolve, in the initial case, a chronic back problem. What has evolved since then is a build-up of, how can I put it, a formulaic approach, where if you have a particular strain of any area of the body, there are formulae from the Jones Institute which describe which points to use, what positions to use, and you end up with charts which can cover your wall and fill your head, just like an acupuncture map, every part of the body prescribed points. And I try to work by deconstructing that model, and it's not myself, many others have worked on in a similar way, by deconstructing to the point where you simply go with what the tissues are telling you. Where is the discomfort? If a patient tells me, raising my arm and stretching backwards hurts me, I ask myself what muscles might be restraining that movement, or what muscles would perform the opposite movement, and it's going to be something in this area, and I'm going to do a very gentle and rapid palpation, find something tender, patient would obviously not be sitting up, would be probably reclining, side-lying, or whatever, or seated. And having found something tender, there could well be 5 or 6 or 7 or 8 possibilities. Find something that's more tender than it ought to be, and then positioning. I don't need the maps, I just need to know which tissues are dysfunctional. What is hurting, what movement is hurting it, not where it hurts, but what movement is hurting it, or what movement is restricted. From there, you have a rapid insight as to where to start looking. And palpation can take 3 or 4 or 5 or 10 seconds. You find something that's unnaturally tender, position it, maybe find something else, and that's all you need to do in most cases. You don't need complex formulae. I hope that answers.
Thank you. Gavin is asking, let me see, in what case would you hold the tissue in a shortened position versus applying pressure in a state of ease?
There are situations, let me try and rationalize that. There are advantages in adding ischemic compression in some situations, or what's known in osteopathic terminology as inhibitory pressure. But in the main, we use for the CounterStrain methodology that I'm teaching, we find that having found something sensitive, it could be a trigger point or simply something tender, and positioning into ease, the maintenance of compression is not necessary. One would probably maintain touch. Let's go back to this one that I pretended to find here. Having found it, pressed it sufficiently to register that it's uncomfortable, positioned it until the score has gone down to a 3 or so. I don't maintain pressure, I maintain contact. So because what has been shown in some studies is that a shift of 1 or 2 degrees from that position and the tissues will fire up again. So if I'm going to stay there for 90 seconds, I don't want 90 seconds of compression, but I want maybe every 15, 20 seconds, just a little, is it still easy, or is it still pain-free, or some such question to the patient. I can't think of where I would want to maintain ease and compression at the same time for any length of time. Perhaps the questioner can elaborate a bit on that question.
Let me see. Actually, that's all it has been asked with that. I'm going to go on to the next because we have a lot of questions and I want to make sure that with short answers we get to as many people as possible. Okay. Would you be able to take us through an example of locked forward flexion by John?
So someone is locked in flexion. Let's go back to the example I tried to give you. So let's just say my wrist is locked in flexion. Okay, so here we have someone who is in anti-flexion. But let's pretend it's the wrist and not the whole body. What are the movements that are going to be uncomfortable? Well, the person won't be able to stand up straight, or if they try to stand up straight, there's going to be pain. So my question to the patient would be, show me what hurts or show me what you can't do. And they can't do this because it either hurts or it's restricted. I'm going to find in the shortened structures 1, 2, or 3 areas of tenderness and position accordingly. If it's, let's say this is the front of the body, well, let's just take it as a forearm and a wrist. We don't have to think of this as the whole body. If I can't extend the wrist easily, there's going to be shortening in the flexor muscles. I will palpate, find something that seems hypertonic. There are different palpation methods we use. We look for hydrosis, increased sweat activity, palpate, compress. Is that uncomfortable? Yes. Whatever you feel there, I'd say give that a value out of 10, and they would say it's a 6 or a 5. I'd say, okay, for the purpose of this exercise, pretend it's a 10. And then I would position, I'd say, give me a score, give me a score, give me a score, give me a score. And by the time it's down to a 2 or a 3, we're there. And then if it's a large area, let's say it is the trunk, I might well treat 2 or 3 in the same way. But after each treatment, I would say, okay, now let's go back and see, can you stand up straight? And if it's totally okay, fine. If it's only partially, then I'd say, okay, let's find something else, and we treat it. It all takes, each treatment, if you like, takes less than a minute as a rule. So we can afford to find several points. So on the flexion, locked in a flexion position, anti-flexion, tender points are likely to be, if it's the lumbar spine is involved, in the lower abdomen, towards near the ASIS area, in the lower thoracic, upper lumbar, maybe on rectus abdominis, somewhere in that area. We'd find areas of tenderness and we'd position accordingly, probably with the patient lying side-lying or lying supine.
Thank you. Can we do, quick answer on that, can we do strain counter-strain as a preventive method?
I suppose if you've got existing hypertonicity, then before you go running or before you do anything too energetic, you might want to release and relax some of the tissues. I teach many of my chronic pain patients, especially those with fibromyalgia, to treat their own anterior neck thorax area. They wake up in the morning feeling stiff. I don't know if that's not so much prevention, but it's a bit of easing of the tissues. They can sit and release these different positions, different tissues. But if you've got something hypertonic, you can modify it with position release, and then exercising is likely to be more safer and more comfortable.
Thank you. From Raul, what are the contraindications of PRT?
Heck, I don't know any. Well, I do actually. Yes, I'm thinking of the introduction to the first edition of my positional release book. By the foreword for that was written by John McPartland, who's an osteopathic physician in Vermont. And John, in his foreword, mentions treating a patient with a hypertonic low back using strain counter-strain. And he had not recognized that the hypertonicity was actually a guarding. So where there is a splinting or guarding, you don't want to release that, do you? And so you have to know the difference between something that's hypertonic and where there is an actual splinting. And if there's splinting, you leave it alone, because he treated this person, and as the person got off the treatment table, a disc herniated. So there was a protective spasm, and you don't take that away. Otherwise, I can't think of many areas. Any contraindications really are, because it's non-invasive, because all you're doing is holding tissues in a comfortable position. It's the degree of positioning. You don't create any new pain. Nothing should hurt. The existing pain should be easier. I can't see a contraindication.
And we cannot end tonight's session unless we give also an answer to Elias Tolos from Athens, Greece, where he is probably...
Kalispera.
Kalispera. So he's probably up at almost 2 o'clock in the morning there.
Well, that's normal in Athens.
So Elias is asking, do you have experience with using PRTs in hypertonic muscles? Example, hypertonic pectoralis major in hemiplegic patients after a stroke, and their short-term or long-term effect, if any, in their function.
I think when you're dealing with chronic neurological problems, the holding time, we talk in general hypertonicity, we talk in 30, 60, 90-second periods of holding. My sense wherever I've treated people with any neurological dysfunction, maybe with Parkinson's or MS or something of that nature, or post-stroke, that the benefits are likely to be, the holding time in ease needs to be many minutes, 15, 20 minutes. That's where I would actually use taping to unload tissues, rather than trying to hold it in that position for any length of time. But I don't have a lot of experience of that, and I would investigate functional taping if in your case, patients at your population, you probably find that functional taping would be the best answer. But I know there are other practitioners who do treat neurological conditions, and they would have more of an answer. I'm not so much in that area. but the length of time would be much longer.
Dr. Chaitow, I want to thank you so much for joining us tonight for this amazing presentation. I would like to remind to those people who are joining us from either the United States or or they want to visit the United States that you will be on April 20th and 21st in New York presenting a 2-day amazing PRT techniques seminar. So I want to thank you once again for participating in our webinar tonight.
Thank you, Dimitri. Thank you for inviting me. Thank you for arranging it.
Thank you. And those of you, my friends, before we end, I would like very quickly to get 2 quick responses from you. One is this one. Please answer it quickly. Whether you have taken in the past a course with hands-on seminars. Let's see some votes there. Couple of more seconds. I'm going to leave it. Very good. And we have 64% of you have never taken a course with us, and we have 21% once, and we have some MCMT and CMT students as well there. And finally, I would like to ask you all, how frequently would you like us to have events like this? You know, we try to have a balance so that these events, these webinars are well attended and liked by all of you. So your feedback to this is extremely important for us, so please vote now. Okay, thank you all so much for your feedback on this. And again, thank you for attending tonight's webinar. And Dr. Chaitow will be with us on April 20th and 21st. And for more information, always visit handsonseminars.com, where you can also view webinars from past events, and also you can register for new webinars such as the webinar on thoracic spine mobilization with Rick Schwartz, and the amazing webinar with Michael Shacklock on clinical neurodynamics. So thank you all, and have a good night.
Good night.